you, Martin. Kia ora, everybody. My name, I'm the Deputy Associate Dean of Health at Awatea on the North Shore campus, and it's my great pleasure to be here today to welcome you to this ongoing series of events that we're doing in terms of professional professorial lectures, but also we're hoping to expand this in the passage of time to master students, PhD students that are engaged at AUT, and also there's been quite a strong demand from staff at Counties Manukau to present at these events. So as things go forward, we'll be looking for some of you perhaps to present at some of these functions. But today it gives me great pleasure to introduce Professor Keith Rowe. Now, AUT is the only place in New Zealand where you can train to be a podiatrist. So Keith is our only professor of podiatry in New Zealand, and he's spent his previous career working in the United Kingdom. He's been with us now for 5 years.
5 years, yes.
And so we're very happy to have Keith with us, and he's significantly engaged with the South Auckland region in his area of interest, which is chronic long-term chronic foot conditions, particularly including gout. So I'm not going to say any more about that, other than Keith will introduce himself and his topic for today.
Thank you. Good afternoon, everyone. Can everyone hear me? Yes, that's fine. Good. As I said, I'm a professor in podiatry, and what I'd like to talk about today is my historical perspective of being here since I immigrated in 2007, and talk about some of the research which we've actually undertaken here in Counties Manukau, but also in Auckland DHB, and particularly some of the work we've done in diabetes, some of the work we've done in rheumatoid arthritis, and some of the work we are undertaking in gout. So those are our key areas we're actually looking at. So, as I said, I'm a podiatrist. I've been in education for about 20 years. I've been in research for about 15 years, and it's interesting, some of the research I've been involved in when I was involved in the UK involved rheumatoid arthritis and, to a lesser extent, diabetes. But since coming over to New Zealand, I've done a lot of work and working with the rheumatologists, in particular relating to gout. But what I'd like to do is give you a reflection of some of the work we have undertaken, but also how important it is to the clinician of the work we actually I'm doing. So what I'd like to do is just to introduce the foot. Okay, structures at the bottom where everyone ignores or tries to cover with footwear and tries to walk around. I'll also talk a little bit about the impact of diabetes, rheumatoid arthritis and gout, and how it has an impact on the foot and the general person. We're then going to talk a little bit about the podiatric management or the foot-related management packages we are currently looking at. I also talk a little bit about current research in respect to diabetes, rheumatoid arthritis and to gout as well, and talk a little bit about future directions, particularly to the professional podiatry and how it has an impact on the multidisciplinary team. So before I start, I'd like to, a big thanks to these people, and particularly to the rheumatologists here at Counties Manukau, in particular Peter Gow, but also the rheumatology team at Auckland DHB and Nicola Dalby for all their hard work and all the work we're actually doing together in looking at these chronic foot conditions. Also to the podiatry staff at AUT for their assistance and their endurance of me supervising them and putting forward ideas related to research, and most importantly are the patients who we are dealing with here at Counties as well as Auckland. So an acknowledgement to all those people. So the foot, a very complex structure consisting of 26 bones, many ligaments, tendons associated with it, very complex vascular supply, neurological or neurological components that go into the foot. Foot pain, as we look at it, is a very common people, particularly in older people. And you can see these figures, it can affect up to 20 to 42% of people aged over 65 years old. It also is to be higher in females than males, although when we talk about gout, we have the opposite scenario. But this is the kind of situation that a clinician, a podiatrist would see, is an older female coming to the clinic complaining of foot pain, regardless of if it's related to the bunion or the heel. but that's the kind of scenario we're actually looking at. If we look at how we actually developed, it was designed, if we go back to evolution, it was designed to walk or to travel on soft natural surfaces like earth and sand. Unfortunately, what we have now is that we walk on and stand on unnatural surfaces like pavement and floors. If you add in poor footwear to this equation, you end up a situation where disaster is waiting to happen, particularly if you're dealing with high-risk feet. For example, those with diabetes, those with rheumatoid arthritis or gout. So these are the kinds of things we need to consider. If we look at this first of the chronic conditions, and I'm just going to go through what we classically see before going on to talk about the management, and if we start off with the diabetic foot, as we know, the diabetic foot is a group of syndromes where you have a number of scenarios related to neuropathy, a lack of nerve sensations, particularly to the plantar surface of the foot, and it has different impacts either related to what we call motor neuropathy or sensory neuropathy, which has an impact on the structure and the shape of the foot. Ischemia, where a lack of blood supply to the foot, to certain areas of the foot, and this could lead to infection, and if you've got a traumatized foot with all these scenarios happening at once, then you're likely, particularly on the plantar surface of the foot, to end up with some nasty scenarios like ulceration, which could end up being infected and leads to amputation, and in some instances even death. So it has grave consequences if the foot is not looked after. In terms of diabetes, and I'm going to focus on MARI because the simple reason is that some of the research we've undertaken has been related to MARI and type 2 diabetes, and I'd like to go through some of the work we've been looking at to this particular population. And the figures are out there, and we know that they are more prone to having problems associated with their feet, and I'll talk about some of those problems in a moment, but there is more of a higher incidence of them getting infections, ulceration and amputation. So we need to be fully aware of that, and it's great that I work with a MARI podiatrist who is an academic as well, and also work with Denise Wilson, who gave a presentation a few weeks ago about the work she's actually undertaken, and we worked together to look at some of the issues related to MARI type 2 diabetes. So a lot of the presentation is related to this particular group. What we know, as I said, is these dire consequences, and I apologise for these gory pictures, and some of you have already eaten, so I do apologise, but we do see in instances some very, very nasty problems, particularly on weight-bearing areas. And what these pictures on the right-hand side are illustrating here is a necrotic area around the heel, and here you can see here under the big toe here where is a weight-bearing area, particularly when you take off on your toes when you're walking, is due to excessive pressure. And when we can measure pressure, which is using a system called a plantar pressure system, this allows us to calculate how much force is being applied to a certain area, which is defined as pressure. You can see here that the more red the colour, the more darker the colour, the more pressure is being applied to the area. And we can do calculations relating to how much peak pressure is occurring under which particular part of the foot. So there's underneath the big toe, that is the heel region. These are the metatarsal heads, the fifth one being there. So you can see we can look at the peak pressures under certain areas and calculate how much force is being applied to that particular area. Because the theory behind that is that if we are looking at an intervention like footwear or the utilisation of foot orthosis, we can apply these devices to try and redistribute the pressure away from these particular areas. It sounds great in theory, but when it comes to the practical side of things, it doesn't always work. And its simple reason is the complexity of the foot interacting with the orthotic, which is interacting to the ground the person is actually walking on. And so sometimes you cannot put that into an equation to work out what's actually happening. But we do have success with through inserts, but also total casts as well, contact casts as well, which try to redistribute pressure as well. So what I'd like to do is just give you a brief overview, and interestingly, because this is a common problem in MARI, is that there's no information about what the foot characteristics are of this particular group. And let's say my colleague Belinda E. Hacker who is a podiatrist and academic, and we actually did some work, just some very, very simple demographic information about the clinical characteristics of a group of MARI with type 2 diabetes. And what we were simply doing is that we're looking at the clinical characteristics of this particular group. It's a very, very small cross-sectional study of only 53 people. And what we did is that we looked at vascular, neurological and musculoskeletal characteristics. We were hoping that the manuscript would have been out before I gave this talk, but unfortunately it won't come out until next month in the New Zealand Medical Journal, but it will be out there next month. And what we've done is just simply described the clinical characteristics of this particular group. And interestingly, in this particular group, and there could be a lot of bias because Belinda does work in this, has been working in this PHO, and it may well be her influence, her impact on education to this particular group, that we found no serious consequences of microvascular or macrovascular complications, which is surprising with all those facts and figures given out by the government and also produced by district health boards. But what we find is that if there is a high prevalence of pre-ulcerative lesions, and if it becomes unmonitored and certainly undetected, then it's likely to lead to some of the problems we have already described in terms of ulceration and perhaps infection and amputation. I think importantly is that, and the emphasis and our main summary findings was that it is important that a screening program is undertaken, and that there is importance to understand that the screening will then lead to the management, and that the management is fully understood and can be implemented within the health sector. And I think that that's very, very important to put across. If we go on to the rheumatoid foot, and this is more in my comfort zone of dealing with rheumatoid arthritis and gout, what we have is that we know that the rheumatoid foot is pretty prevalent, and foot involvement is very, very high. Up to 90% of cases who are defined with rheumatoid arthritis do develop foot problems. And what you have is pain, stiffness and fatigue, which leads to a decreased functional activity, i.e. to walk from A to B without being in pain, because that is their main problem, is the pain associated with walking. And if you ask any rheumatoid patient with established rheumatoid arthritis, is that they will describe it's like walking on pebbles. So they do suffer a lot with their feet. And because of the X-ray progression is early, what happens over time, you do get degeneration of the joints, that instead of a joint being nice and flexible, becomes rigid. And that rigidity, together with the symptoms associated with rheumatoid arthritis, makes the foot highly incapacitated in terms of doing a simple activity of going down to the shops and picking up groceries. Sorry about the very, very busyness of this slide, but what I'm trying to put across here is that you've got the rheumatoid process of synovitis, which does affect the major joints of the foot, which we describe as the subtalar joint, or the talonavicular joint is also affected as well as the ankle joint. What happens is you get erosion and deformity in this joint, which leads to the impairment. It then causes an impaired function on the individual, so they alter the way they function and they alter the way they walk. So you may find a rheumatoid patient with an established disease shuffles because it's very painful to put their feet in contact with the ground. So they change the way they actually walk, and that causes more pressure or more forces on other joints to change. And so you get this vicious circle actually occurring. And so you get all the problems of disability, of activity limitation, and participation restriction. So you've got this nasty vicious circle in people with established rheumatoid arthritis. When we look at different components of the foot, and I'll talk about the metatarsal phalangeal joint, or the forefoot is the under the sole of the foot, under the metatarsal head, you see classical features of people with very severe bunions. You get clawing of the lesser toes. HAV, sorry, is my abbreviation for bunions. You get prominent med heads, as you can see here in this particular picture, and you get build-up of callus underneath there as a form of protective mechanism. And these, in some instances, do lead to ulcerations, particularly if it's untreated. So because of some of the vascular problems and some of the neurological problems they get with rheumatoid arthritis. So you can see by this plantar pressure reading here how much pressure is occurring underneath each of these metatarsal heads. And that's what they complain about, the pain associated with rheumatoid arthritis. It's like walking on pebbles or walking on glass. That's a typical experience we actually hear from patients. If we look at the rear foot, the back part of the foot, we see a classical flat foot. They are excessively flat-footed. I call it pest pancake feet. It's not a correct terminology, but it's a very, very flat foot. The mid-tarsal collapses, and you do develop calluses and bursas and ulceration in rheumatoid patients as well. And again, the plantar pressure reading here illustrating this foot, so you can see on the heel region here, on the midfoot here, and underneath the hallux as well. As you can see here, it's very, very, very prominent. And a lot of occasions we don't ever see, in established cases, the toes in contact with the ground. So they have to take off on their foot, instead of the big toe, other parts of the foot, which could cause more damage. So, you know, pretty depressing picture I'm painting here in an established disease. All this has an impact on the person. They do have increased pain, disability and impairment, and what they tend to do is walk much slower with more contact with the ground because they feel more comfortable with that scenario, but that leads to increased pressure. So that's the kind of scenario we see in the established one. What we would like to see is early rheumatoid patients who have got good ranges of movement, where some kind of non-surgical intervention could be undertaken to prevent the foot getting into this stage. So it's a window of opportunity, I think has been mentioned many times in a lot of these long-term chronic conditions. Now, on to gout. As I said, when I first came here to New Zealand, gout in the UK wasn't that prevalent, and I worked in a number of rheumatoid clinics, and we didn't see that many gout patients, but here it is very, very prevalent. And I was very surprised after going down to the super clinic, to one of their super gout clinics with the rheumatologist, and spending the day there, and just surprised to see the amount of gout in men, particularly younger men, which was a bit of a shock to the system to see these people with this severe disease. In terms of prevalence rates, you can see by these figures, and particularly the American one, it's pretty high. Up to, to have 3.9% of the American adults having some kind of gout, this metabolic problem, which is associated hand in hand with diabetes, and obviously obesity is prevalent as well, and they all go hand in hand. But also the rates in New Zealand have increased. In a recent paper written by, I think, rheumatologists here at Counties Manukau reported these figures as being pretty high, particularly in Maori and Pacific Island people compared to Europeans. But it's still, they're very, very, very high figures. As we know, Auckland is termed the gout capital of the world, which is, I don't know if that's a good thing or a bad thing. This is a scan of the foot, and these illustrate, and I hope you can see the redness here because I'm a little bit colourblind and the screen is not very good, but you can see here these are tophi, the crystals which form around joints, and you can see here it's very, very prevalent over the big toe or around the hallux. But also what you can see is it is prevalent on the medial side of the foot. But what we are finding, and I'll talk a little bit more about this, is that we are finding these tophi affecting the Achilles tendon as well, and this has major impact to everyday activities, and particularly those men who want to participate in sport to have those kind of issues. But I'll talk a little bit more about the work we're doing around Achilles tendon a little bit later on. So how does gout impact foot function? And what we did, we started from the very, very beginning because we knew nothing about the foot and ankle characteristics, although it is very, very prevalent in the big toe. But no one has looked at what is the characteristics. And hopefully you can see that at the back, and not to read the abstract. The abstract is just to illustrate that we started by looking at a group of chronic gout cases, and what we did is we compared the characteristics to those without gout. So it was a case control and age and gender matched, and we looked at those characteristics. And what we actually did is that 25 of these people were evaluated, and we looked at foot function, we looked at foot disease, the foot pain, but also we undertook plantar pressure readings and gait assessment, just to give us an overview of what we're actually dealing with. And what we found, which is no surprise really, is that patients with chronic gout have a high levels of pain, disability and impairment associated with their foot. The plantar pressure readings, without getting into too complex detail, illustrates, instead of trying to walk on a very, very painful bunion, is that they adapt their gait to avoid that particular area. So they change the way they walk to avoid those particular areas. And when they do that, they deliberately walk much slower than a person without gout. So there's massive changes in terms of their gait, which does have an impact on other joints in the lower limb, i.e. the whole of the body, in terms of walking or even doing physical activity. So the conclusions from this particular study was that chronic gout sufferers do have a high level of pain and disability, and they use different strategies of walking to undertake their everyday activities. Now, we're also interested in acute gout. This is, and if anyone I've never experienced, but patients who tell us who suffer this, is the most immense pain that men, I emphasise men, have ever suffered. So, and I won't say any more than that. It is very, very painful. And what we did is a very, very similar study, but we were interested in other clinical characteristics in this particular group. And when we started this study, we thought, oh, it would be quite easy to recruit 25 people into a study. But we went to Auckland DHB, went to Counties Manukau IRD, we got the ethical locality assessment, and they said, what would be a good idea is to come into accident and emergency, because that's when you'll pick up people. And to our surprise was that when we went to accident and emergency, people were coming into A&E with acute gout attacks and being hospitalised because of this problem. Now that must be a massive burden on the health service for a disease which could be potentially maintained. So it was a surprise to me and a surprise to our particular researcher, but it took us a long time to actually gather this information. And again, what I'd like to talk a little bit is about some of the pain and disability this particular group of individuals suffered from. And as I said, what we did is that we measured a group of acute gout patients. We measured them at baseline when they were in the most immense pain, and then we measured them 6 weeks later, and we were looking at some of those classical clinical characteristics. So we only recruited 20 people, but that took us 12 months. It wasn't easy. A lot of people didn't want to be involved in the study. In their immense pain, the last thing they want is someone to prod their toe and take measurements of their foot. So it wasn't easy. It sounded great on paper, but in reality it was quite difficult. And what we did is we measured them at the time of the flare, and then we reassessed them follow-up 6 to 8 weeks later. And again, we used very, very similar measures which we used in our chronic gout study. What we found, again, no surprise, high levels of pain and disability. But after 6 weeks, their pain levels reduced, but not to baseline. They've always had some level of pain. So that's something of interest, is that there is some pain. Also, their blood count didn't go back to normal values. Again, some of the CRP values were high. So therefore, when they do have an attack and they're not and the medication which is given or prescribed to them, they're not actually taken, they're always in some level of pain. So that goes back again to how do we as healthcare professionals, and obviously the rheumatologists as well, deal with people who are non-compliant, particularly with the medications that are being prescribed. Right, so those are an overview of some of the 3 common conditions we have looked at. And there are many, many other conditions which are around, but I focused on these particular 3 because these are the ones we have been looking at. Outside New Zealand, I do some research with people in the UK and Australia related to multiple sclerosis and textured insoles, but I'm not going to talk about that today, just focus on these particular groups. And now I'd like to talk about some of the management plans that we've come up with and what is being utilised at this moment in time. The role of the podiatrist, this is what we believe we do. What other people outside may think is it may be slightly different. But particularly in the rheumatic diseases, the primary aim is try to reduce pain. A lot of times we're dealing with established diseases, we can't change function, so we try to make them as comfortable as possible. In diabetes, it is the prevention of foot ulceration, but overall, we're trying to enhance their quality of life and reduce some of the disability in these particular groups. We have a number of management strategies we use. We have footwear, we have foot orthosis, we look at foot education, we look at foot promotion. This is, an oversimplistic overview, but this is our main armament we use to help individuals with long-term chronic foot conditions. I think the most important thing is that working in a multidisciplinary team is so important. It's not to work in isolation. We do excellent work. I know my colleagues in diabetes do work in a multidisciplinary team. We have just set up a podiatric rheumatology service, which I'll talk about in a moment. Again, we work within the rheumatology team because otherwise you can't work in isolation. We have a role to play. And obviously, any kind of the medications the person on is encouraging them to ensure that they do take the drugs which have been prescribed to them. In terms of the assessment side of things, and I talked briefly about the assessment and won't go into great detail, but more focus on the management, is that it is important that we understand the pathways involved and that screening programs can be put into place, particularly in diabetes, is to make sure they don't develop these nasty lesions. And education, we think, is a key component to how we get around it. And I'm sure, in the audience, everyone is trying to promote education, and it's a key component. But it is a barrier, and we have the same issues as most other healthcare professionals in respect to trying to put over what we believe is the best way forward. Very quickly, we do a 30-second examination without having using great sophisticated technologies around. Is look at the history, look at the vascular status, look at neurological in terms of protective sensation, and look for significant deformity, and just mark what they've got without having to use plantar pressure readings, without having to use more sophisticated kits, because simply we want to get an overview of what they actually do. But we do have sophisticated kit which we can use in respect to looking at each of these particular components. The rheumatoid foot, a little bit more just about the rheumatic foot, is that relying on, particularly on musculoskeletal ultrasound and some of the other imaging techniques that's around to give us some idea of pathology and function and structure, gives us a better understanding, a better grasp of what's actually going on. And this will be the same for diabetes as well, in using imaging techniques to understand a bit more about the pathology we're actually dealing with. Now, quite a controversial statement here and is about callus reduction, and this is related to the rheumatic diseases, not related to diabetes, is that do you reduce callus in rheumatoid patients or not? And my rule of thumb is normally when we tell our students is always under-reduced, never over-reduced, because one, it leaves the metatarsal heads quite exposed but secondly, the research which has been undertaken is that it does reduce some pain over a very short period of time, but over 7 days it goes back to where it was at the beginning. So callus reduction in the rheumatoid foot may not necessarily be okay and may not be appropriate, whereas we know in diabetes callus reduction is important to ensure that if a wound dressing is going to be applied, or you're trying to put forward the idea of a foot orthosis or modified footwear, that it actually can work without having the callus, which can reduce the healing times in those particular feet. Simple insoles have been shown to be effective, particularly in rheumatoid patients, and it's very, very simple insoles which you can buy over the counter. You don't have to go to sophisticated lengths to have something custom made. In a lot of instances, these do work quite effectively. So, and the use of an additional bar or a dome does help these people as well. The mechanisms of why a little dome on the sole of the foot works is still open to interpretation. I'm not quite sure understands the reasons why. We do have something called functional foot orthosis, and these are the one which are prescribed by healthcare professionals, which can either be bought over the counter or they can be custom made for the individual. And the plausible mechanism, and I use the word plausible because no one really knows the real mechanisms of action, is that it tries to control motion. Now that's great if you've got good ranges of movement in the foot, but when we're dealing with high-risk feet, which are established, they are rigid and there's no motion control. So that therefore these devices go out the window. You can't use them. Try to decrease pressure and force, yes, that may be the best way forward, particularly in these long-term chronic conditions that we're dealing with. And there's ways of changing the orthotics by adding, I would call bits and pieces to it. You can add things to the rear foot and other additional materials as well. And there's been a lot of material science into which materials is best for which particular group. So a lot of people, for example, in diabetes, use a diabetes poron, which is supposedly a specialised polyurethane foam to help these patients. We have patients who do self-management, and this is a great case we picked up. And here's a piece of carpet here which the patient thought would be the best way of dealing with it. It's quite they did very well, cutting the hole out where it hurt. But whether it's effective or not, I question that.
But you mean the carpet, the design on the carpet?
The design on the carpet, yes. I didn't like the colour. Yeah. We do give a lot of advice on footwear, but this is perhaps the most controversial area, and it's the area we're actually looking at on footwear advice. We think the vehicle is the most important thing. You get the footwear right, you're going to help that patient, particularly if you want to add anything else like a simple insole inside their footwear. And other forms of intervention, I've just put down hosiery. Diabetic socks have been around for a number of years, and they said they're meant to be pretty effective in reducing some lesions. The evidence is a bit sparse on that, but that's a potential area. And the use of emollient creams as well. And again, there's evidence to support that emollient creams and hosiery together work very, very effectively, particularly in diabetic feet. Education, we always try to, our goals is self-care management and encourage self-care behaviours, and really patient identifying what the problem is and making sure it doesn't get to an acute stage, and by good advice on footwear is very, very important. Self-care behaviour, as you say, is that we have a scenario of trying to get the people to educate people about their feet, about how to inspect their feet, to look for any lesions. If able to cut their toenails, a lot of instances they're not able to cut them straight across, apply moisturisers and creams. Hard skin by emery boards, not by the corn plasters which are advertised on the TV or in the chemist. Try to avoid barefoot, which is not easy, particularly in the ethnic groups where barefoot is quite a natural occurrence. But they're more deemed at risk to walking around bare feet, and to look at footwear, particularly for wear and tear. So these are the kinds of self-management strategies we try to put in place, and we've been working with Arthritis New Zealand to put this across, and we developed their pamphlet on the care of the feet for the rheumatoid patient, and some of these basic principles we try to apply to patients. Now, I'd like to talk about an intervention trial which when I first came over, was just starting, and I was there for the duration when it completed, and it's a very, very interesting trial. This was funded by the HRC, and it was looking at MARI in terms of some of the risk, particularly related to diabetes and their feet. There were a number of aims, but I'm just going to put the main aim up. It was really to develop and implement and evaluate an intervention, a podiatric intervention for MARI with diabetes, which was acceptable to MARI itself, to the people itself. And so working in a large team of MARI healthcare professionals, which included podiatrists, to see if an intervention would actually work for MARI people. It was multi-method. It had both qualitative and quantitative processes in it, and really the informative phase was using focus groups and interviews with groups of MARI people, looking together with the literature, the current evidence at the time, to put together what was the best podiatric intervention for these particular people. And it was no different from what I've already talked about earlier on this afternoon. We also did an intervention study which was over 12 months. We had a group who got the full works, and that sounds an awful word to use, which was the list is described here as education, the use of skin emollients, hosiery, foot orthosis where they needed, referral to other health services including social services, appointment reminders, provision of transport or home visits, and invitations to a self-management group workshop. So all these were put into place for the intervention group. The control group just got standard podiatric palliative care, which included some of the elements but not all the elements into this particular group. And then we measured them over 12 months. What we found was that diabetes knowledge was retained by the intervention group after 12 months and was significantly reduced for the control groups. And knowledge, understanding about the feet was certainly significantly reduced in the control group if they weren't reminded and weren't integrated into what we were trying to put across to them. The attrition rates in the intervention group was 17%, the control group 28%. We did have high attrition rates, but you have to look at these figures and understand why we found these particularly high figures. What we found is that many intervention participants were referred to other health services. It wasn't just purely the podiatrist who was involved, it was involving the dietitian, it was involving the GPs, involved seeing a diabetic nurse as well and referring on to them, working in this multidisciplinary team. And interestingly, 64% of the control group had never seen a podiatrist. So that was interesting, which was a fact which was a bit of a surprise to us. We thought they were seeing a podiatrist, in fact they weren't. So it shows you that people with diabetes don't necessarily use a podiatrist and feel quite hesitant, as a barrier to go and see a healthcare professional. And what we found is that the foot care is a crucial part. And although I haven't given the full picture here, there was a lot of interviews going on, and they gave us a rich history of information, particularly about accessing podiatry services and can't afford to pay for a service. But when we used interventions, the terms they used to describe how lovely it was to use creams, or particularly to use the diabetic socks, was very, very interesting, and it was very, very nice to read those particular kinds of information. Again, I apologise for the busyness of this slide, but our main summary at the end of doing this trial was that what was that we're trying to put the idea of trying to get to the end stage of amputation, and that education and diabetic knowledge, particularly related to the foot, is crucial. And if MARI are involved in this process, we're probably going to see more success than if they weren't involved. and involved in the communities and key stakeholders is crucial. And I'm sure this message has been put across many other interventions, the same kind of messages which are used. So at the end of the day, we found this, and future directions is looking at ways of trying to implement a podiatric intervention to try and prevent some of the amputations we see in this highly prone group. Now, if we go on to gout, yes, of course.
Can I just ask a question about your...
Yes. Do you want me to go back?
What were the costs initially? It's like, you're putting all these resources into an intervention
Yes.
program, and then like the potential cost savings from not giving people, progress to amputation stage. And was that, were you able to
No,
predict or...
not in this study. No, we from the commentary we were getting from some of the comments made, it gave us the idea to put forward a proposal to HRC looking at cost effectiveness. So to answer that question is what we are planning to do for next year.
And is that something that is kind of going to be looked at to address, the high incidence?
Very much so, yes.
Not just mouldy, but Pacific as well. We have high incidence of diabetes. So.
Yes, the answer is most definitely yes. A little bit later on, I'll go on to talk about current directions, and I'll talk about the exact point you're making. Hopefully that will answer it. If it doesn't, I'll certainly respond to it. But certainly yes is the answer, yes. Thank you for that. As I said, gout and footwear. We were interested in, well, as I said, we're interested in footwear because we think it's the most important vehicle to look at in terms of prevention for these people. And what we did is that we conducted a simple observational study looking at the characteristics of people, gout people with footwear problems. What we found is that we measured 50 people at the super clinic, and what we found was that this was a typical pair of shoes, by the way. This is what someone came in with. And what we found was that the shoes they were wearing through a standardised format is that they were over 12 months old. They've had difficulties in finding adequate width. Now this is no different from a rheumatoid patient as well. And they had poor cushioning, poor midsole stability. And what's that? That's the midsole is the middle component of a shoe which gives it stability so you don't wobble from side to side. And more importantly were the costs. A lot of people could not afford new shoes because of the high cost of what we were looking for. So that's a very, very interesting finding. Now bear in mind these issues we found, because when I talk about rheumatoid patients, we find very, very similar issues as well. What we found, and don't get too bogged down in the technicalities of this slide, is again we found severe pain, disability and impairment with these individuals. And what we try to do is try to correlate this pain and disability with the shoes they were wearing. And what we found was that they correlated, that the poor footwear, the footwear which didn't have any of the classical characteristics we were interested in, correlated with pain. So poor footwear equates to some of the pain and disability and impairment they suffer from. So this is the kind of work where we're looking at, and I'll talk a little bit more about some of the current research we're looking at in a moment. Now we also did it with rheumatoids as well. We were looking at whether we would find similar findings in the rheumatoid population, and what the aims were was that we were looking at footwear style, footwear characteristics, and factors that influence patients' choice, patients' perception of what they feel is important. We categorised shoes, and this is perhaps the most controversial of all the slides, by an American study. And this may not be applicable to New Zealand, but this is what we went on, and maybe people will argue that wearing sandals and sandals, particularly in the summer, is not deemed poor, but should be deemed good. But if you take into effect their rheumatoid arthritis, then it is a poor footwear for that particular group. I'm not saying everyone is poor for wearing sandals and sandals, because we all wear them in the summer. But for rheumatoids, it is defined as poor. So this is our categorisation of footwear. What we found was that most people wearing sandals or sandals They're also wearing walking shoes and court shoes as well. Very few people were wearing orthopaedic footwear, which has a massive cost implication because of the amount of patients which are referred to the orthotic centre. And my colleagues in the UK talk about shoes in the cupboard. A lot of money is spent on these shoes. What happens to them? They end up in the cupboard because people will not wear them. And there's a big body image, particularly related to women and rheumatoid arthritis, to wearing these big, black, ugly boxes, as a lot of them describe it as. So, and a lot of rheumatoid patients talk about that and the problems they have with that perception. What patients perceived as being important was comfort, which is no surprise. Fit was important, giving them good support. A low heel and getting the shoe on and off were important factors. Weight as well, those were the most important factor. But comfort was the biggest one. So what we find is that footwear deformities make it difficult to find adequate shoes. We believe that open-toe footwear lacks supportive mechanisms in terms of cushioning and protection, and could possibly contribute to the disability in this group, and that comfort and fit are most important factors. And that if we are going to prescribe, then wearing some kind of strap or some kind of buckle is important. So the current footwear choices are poor, and the choices in finding good footwear is difficult. So there is a need of good footwear, but what is defined as good footwear, and can we find it in New Zealand? The answer is at this moment in time, no. It's very, very, very difficult. But if we can incorporate some kind of knowledge base to both the patient and to practitioners, then we'll probably take a good step forward. We do have challenges, though. We do know that with patients with gout and rheumatoid arthritis, it affects the hands. And so therefore, if you're going to prescribe a shoe which has got laces or something like that, then you're going down a dead alley, basically. It's very, very difficult to say that. So just to finally come into the last area and talk about the current work, I'd like to talk about the rheumatology service we've set up here. It's funded by Countess Manukau and Peter Gow's team down in the Super Clinic. And this is the first service in New Zealand. We based it on a number of previous studies which I've described. We then put these papers together and just try to justify the need for a service through this particular paper, which was published in the New Zealand Medical Journal a couple of years ago. What we did is that we started the service in July 2010. We employed 2 part-time clinicians who work in diabetes, and we trained them to work in rheumatology. It was an interesting story on how we got there, but now they work very effectively, and they know hopefully they know what they're doing. They do know what they're doing. And what we do is look at a group of rheumatic diseases. We did a survey over our services over 2 years, and what we found is that 252 people referred into the system, and we use validated outcome measures, and what we have found is that we found from the baseline to their next visit an 18% reduction in foot pain and a 28% significant reduction in foot impairment. So what we're offering to people demonstrates that we can make a difference to these particular people. The manuscript has been submitted to the New Zealand Medical Journal, so hopefully in about 6 months, 9 months' time, it will be out there in the public domain to see what we actually found. And what we also did is a patient satisfaction survey, and we surveyed over 148 people. We've got a response rate about 42%, lowish. But what we found from their responses is that they found that the service was appropriate, was good, and it did help their foot problems. So that's from a patient's perspective as well. So I think very, very important figures to quote.
Did you have any issues around DNA rates to your clinic?
It's a good question. I don't know the answer to that. That's relating to who don't come back for subsequent visits.
Yeah, even like first sales or
right. I don't know the answer to that, but certainly it's a good question, and we should be looking at. There's another point is that we didn't know. We're looking now. We're analysing the data in terms of the ethnic breakdown of how many people were seen and who didn't return for the next visits. because particularly some of the chronic cases we're dealing with of not returning. Now, some of the other work we're doing, we just got funded by HRC to look at a feasibility study into gout and footwear, and it's looking based upon the previous work we've actually undertaken. And what it is that it's a randomised clinical trial, and where what we're looking at is trying to come up with a competitively priced footwear which mimics the most expensive shoes which are around. So we're trying to look at footwear which is under $50, we're probably asking a lot here, but has got the same clinical or the same footwear characteristics as an expensive walking shoe. I don't know if you can see that, and I apologise for the smallness of the slide, it's more on the screen, but what we call as an ideal shoe, based upon our previous studies, is that it has to be cost effective, it has to have good cushioning, it has to have good width, it also has to have good motion control and good midsole stability. We have found a range of shoes, in theory this is, that match some of that criteria. And as you can see at the bottom line, shoe D, as it obviously is the most expensive, is your classical one you find in any footwear store, retailer. Now, also related to gout, we're interested in ulceration as well, and this was funded by New Zealand Wound Care, and what we're trying to do here is just simply give some clinical characteristics to these people with chronic ulceration associated with gout. We know that gout and diabetes go hand in hand, so we're hoping to recruit people into the study regardless if they got diabetes. Let me say that. They got gout and diabetes, we would take into the study. So we're looking at a number of different characteristics, and this is a case which has been seen by our podiatrist at the super clinic, which we've been treating with wound care dressing and also being treated by the district nurse as well, and this has improved dramatically. But what we're doing is that we're looking at demographic characteristics, we're looking at the size and shape of these ulcers, we're also looking at disease measurement and foot and ankle assessment, but also the quality of life from the patient's perspective as well. We're using something called the Cardiff, and I've forgotten the name of it, I wish I wrote it down. It's a quality of life, and it's called Cardiff something something, and I can't remember. I will remember it in a moment. But these are kind of features we're actually looking at. As I said, going back to previous work of looking at the foot and ankle characteristics, Matt, who's in the audience here, he's doing his work on looking at Achilles tendon and looking at its function and how it's impacting in terms of walking and disability. And what we're trying to do is try to get some imaging of this problem. Suddenly we realise, and the rheumatologists have found at Auckland Medical School, that there are high incidents of tophi around Achilles tendon. So what we're going to be doing is taking ultrasound imaging, but also we're looking at how people actually walk as well and look at the relationships between those two variables. So ultrasound measurements will be undertaken, looking at these key characteristics of what's happening there, and then what we're trying to do is match it. It looks really complicated, and it is, is trying to match how they actually walk with some of these clinical characteristics and see if pain and disability is associated with these particular problems. We're also looking at falls in rheumatoid and seeing if foot and ankle characteristics are associated with it. Now, we've done some work looking at postural sway and falls in an older population in the UK, but what we believe is that rheumatoid patients are more prone to falling. And it could be, I'm not saying it is, it may be associated with falls. So what we're looking at is specific foot and ankle characteristics in this particular group. Again, what we're doing is recruiting from here and Auckland DHB as well, looking at these particular people. And what we're trying to do is come up with a predictive model, which factors may likely to lead to why people with rheumatoid arthritis fall. As we know, when we assess and we manage our patients with rheumatoid arthritis, they always feel very unsteady on their feet and they feel like they're going to fall. Now, is that due to foot and ankle characteristics, or is it due to more complex processes? I actually imagine it's a combination of both. So we're going to recruit 200 people from here in ADHB. We're going to take a number of baseline measures, and then we're going to follow them for 12 months with a fool's diary as well to see if that has any impact. So, future directions. Where do we go from here? What we're looking at. I've written a list here, and I think importantly, we're looking at individual components of a whole package. And I think self-management package is very, very important, particularly in rheumatic disease and diabetes. And we will be looking at clinical and cost effectiveness. And I think it's very, very important to see if we can save money. I think also from our own professional perspective is to promote a podiatric rheumatology practitioner. We have people in diabetes, but I'd like to think, and as I said, I've got a bias towards rheumatology, and I would like to think that we can promote and support clinicians who want to go down this specialised route and to work in a multidisciplinary team. And I think we've got great opportunities, particularly here in Counties Manukau, to do that. And also, the service we've set up is the first service in New Zealand, and I think we can roll it out to other DHBs. We know funding is so tight nowadays, but there is a possibility, particularly if we're making an impact on people's health. I think it's very, very important. And the last one is a unique one, is that it's trying to disprove what a podiatrist is. It's not just simply a toenail cutter. You may laugh at that, and it's like, no disrespect, occupational therapy is a basket weaver. I'm sorry to say that.
No,
But
I make very good baskets myself.
yeah. But it's to get round that perception and head some of the research and I think working in a team is so important to illustrate our role. And the last thing, just to illustrate, and it goes back to that point, is just one of the current directions, and this is what we're working towards, is that we're working towards trying to come up with a cost-benefit analysis to try and reduce amputees, particularly with type 2 diabetes with MARI. And this is one of our goals. One of our aims for next year is to put a full proposal in a programme grant to HRC to try and address some of those particular issues. So really what we're looking at is trying to look at a podiatric intervention and trying to see if it has an impact on individuals trying to reduce these large amputee rates. And just a couple of more slides is just to illustrate what we can do when we say usual care to comprehensive care. As you can see, the package we are looking at is all about knowledge base. It's all about the use of mechanisms like footwear, insoles, hosiery, referral to other care, primary and secondary care, and also counselling. This is what we would call as a comprehensive foot care package. That's what we would like to see happen for individuals with diabetes. And the very, very last thing is that we've launched a specialist interest group about a year, 18 months ago. And if anyone's interested, you can just click onto this website. It doesn't cost anything. It just gives you, when the latest conferences are, a little bit about rheumatology, feet, and also we do a review of the current literature, anything related to rheumatology. I give a very brief overview of current literature related to these areas. So you're welcome to access the site and to see what kind of information is on there. So in conclusion, I think podiatry has a role to play, and it does make a difference to the long-term chronic conditions we actually deal with. Our current research is promising, particularly in rheumatic diseases, but further research, particularly in diabetes, is needed, and that we need to look at preventative methods, and particularly some of the interventions we put forward that are both clinical and cost-effective, I should say. And I think development of podiatry in the workforce is important, particularly from us as educationalists, and as also for an impact within the health service that we do have specialised podiatrists within the health scheme. Thank you. No one's falling asleep.